Hello guys, today we will look at acute suppurative otitis media. It is a really important topic in ENT. So first we'll start with the definition. Acute suppurative otitis media is the acute inflammation of the middle ear by pathogenic organisms. So initially there is involvement of middle ear mucosa which later on involves the whole middle ear cleft which includes the middle ear, eustachian tube, attic, otitis and mastoid antrum including the air cells. The pathogenic organisms are pus producing organisms. Now we'll look at the etiology of acute suppurative otitis media. So initially there is viral infection of the upper respiratory tract. So these viruses may be human rhinovirus, respiratory syncytial virus or adenovirus, etc. And then after these infection by virus there is invasion by the bacteria. So the most common bacteria involved is Streptococcus pneumoniae. Haemophilus influenzae and Moraxella catarrhalis are next most common. Other bacteria involved include Streptococcus pyogenes or Staphylococcus aureus. So now we'll look at the routes of spread of this acute suppurative otitis media. Uh, Most common route of spread is eustachian tube. So infection will travel along the lumen or peritubal lymphatics of the eustachian tube. So initially there is infection in the nasopharynx which is transmitted along the eustachian tube into the middle ear, leading to infection of the middle ear. So it is most common in infants because they have shorter, wider and horizontal eustachian tube, especially during breastfeeding or bottle feeding in supine posture. It is also seen in swimming and diving. So in these cases, there is a force. The fluid is forced through the eustachian tube into the middle ear, leading to infection of the middle ear. And other routes of spread include external ear and bloodborne. So external ear, it can spread via pre-existing tympanic membrane perforation or traumatic perforation of the tympanic membrane. Bloodborne route of spread is very rare and it can also spread via fracture of temporal bone. Now we'll look at the predisposing factors of acute suppurative otitis media. So the predisposing factors can be remembered as broad categorization of infections, tumors or any kind of allergies. So in infections there may be recurrent upper respiratory tract infection which is the most common predisposing factor. Other predisposing factors include exanthematous fevers, chronic rhinitis and sinusitis, infection of the adenoids, tonsils, and in allergy there may be nasal allergy or cleft palate or palatal palsy. In tumors there may be tumors of nasopharynx or any kind of immunocompromisation of the host or barotrauma which is trauma due to change in pressure in the middle ear. Now we'll look at the pathology and clinical features of acute suppurative otitis media. So the clinical features include five stages. Stage 1 is a stage of tubal occlusion. So in stage of tubal occlusion, there is initially hyperemia and edema of the eustachian tube initially at the nasopharyngeal end. So due to this edema at the nasopharyngeal end, there is obstruction of eustachian tube. Due to obstruction, there is a negative pressure in the middle ear. Due to negative intratympanic pressure, the tympanic membrane is pulled inwards, so there's retraction of tympanic membrane along with middle ear effusion, which is generally not clinically significant at this stage. Now we look at the symptoms and signs of first stage. So the symptoms include earache, mild hearing loss, but there's no fever in this stage. In signs there's retracted tympanic membrane. So the features of retracted tympanic membrane will be the tympanic membrane becomes dull, lusterless, there's foreshortening of the handle of malleus, distorted cone of light and prominent lateral malleolar folds. Along with that there's conductive hearing loss seen, which can be examined by tuning fork tests or other methods such as pure tone audiometry. The normal tympanic membrane is pearly white or grey. It has a luster. The handle of malleus is normal and the cone of light is seen in the anterior-inferior quadrant with non-prominence of lateral malleolar folds. But in retracted tympanic membrane, it becomes dull. There's cone of light will be distorted. There's prominent lateral malleolar folds and handle of malleus will be shortened. And next we'll look at the stage of presuppuration or exudation. In this stage, due to prolonged tubal occlusion of the eustachian tube, there's invasion of the eustachian tube into the middle ear. So after the invasion by pathogenic organisms, there will be hyperemia of the lining of the middle ear. Due to hyperemia, there is inflammatory exudation of the fluid into the middle ear, which is clinically significant in this stage. Now we'll look at the symptoms and signs of stage of presuppuration. So first we'll look at the symptoms of presuppuration. The symptoms include fever, earache, hearing loss, and tinnitus. So fever is of high degree, which along with restlessness. Ear pain will be marked and of throbbing nature. There is hearing loss and tinnitus, which is more appreciated in adults, but in children there is only ear pain, which is marked. Now we'll look at the signs of second stage, which is the stage of presuppuration. The signs include the tympanic membrane will have an appearance which is known as the cartwheel appearance. So in this, the tympanic membrane will become congested, really red and congested, and leash of blood vessels will be seen along the handle of malleus and the periphery of the tympanic membrane, which will give rise to the cartwheel appearance of the tympanic membrane. And then the complete tympanic membrane will get uniformly congested and red. The tuning fork tests will show conductive hearing loss in this stage. So now this is the tympanic membrane of the right ear. When there's leash of blood vessels along the handle of malleus and the periphery of the tympanic membrane, this will give rise to the cartwheel shaped tympanic membrane. Now we'll look at the stage of suppuration, which is the third stage of acute suppurative otitis media. Suppuration means formation of pus. So in third stage, there's formation of pus in the middle ear, which may extend into the mastoid air cells. The tympanic membrane will bulge to the point of rupture. Now we'll look at the symptoms and signs of third stage. So symptoms, initially there's fever. The fever will increase with constitutional symptoms such as vomiting and convulsions. There is ear pain which is excruciating in nature, and the hearing loss will increase from the second stage. The signs, tympanic membrane will become red and bulging with loss of landmarks of the tympanic membrane. The tympanic membrane will be so much enlarged and bulging such that it will engulf the handle of malleus. There'll be a yellow spot on the tympanic membrane where the rupture is imminent. Tenderness over the mastoid antrum may be seen if the mastoid air cells are involved. The HRCT temporal bone and X-ray of the mastoid reveals clouding of air cells in the mastoid. Okay, then fourth stage is the stage of resolution, in which there is rupture of tympanic membrane. So the symptoms will resolve and inflammatory process will also resolve. Sometimes this stage of resolution occurs even without rupture if there is appropriate antibiotic usage for a proper period of time. So now we'll look at the signs and symptoms. So in this, the fever and earache will resolve. The ear discharge will be seen. So since now there is a perforation of the tympanic membrane, ear discharge otorrhea is seen. So due to perforation, so initially the discharge will be blood stained, which will later become mucopurulent. Now we'll look at the signs of stage of resolution. The external auditory canal will have blood tinged or mucopurulent discharge as seen already. So this is known as pulsatile otorrhea, which will give rise to a lighthouse sign, which refers to release of pus under pressure, which will give rise to an appearance such as lighthouse appearance, which is known as lighthouse sign. And then there'll be perforation of the pars tensa, will be seen in the anterior inferior quadrant most commonly. It can also involve the other quadrants. Tympanic membrane will return to its normal color and landmarks. So as the inflammation will resolve, the tympanic membrane will become normal. Now we'll look at the stage 5, which is the stage of complications. So if the virulence of organism is high or if the host resistance is low, the spread of the disease occurs beyond the middle ear, which may involve the mast or even middle cranial fossa involving the facial nerve, etc. So it may lead to mastoiditis, petrositis, facial nerve paralysis, etc. Now we'll look how to diagnose acute suppurative otitis media. So first we'll do tuning fork test. So in tuning fork test, we will see conductive hearing loss. That is, when we do Rinne's test, it will be negative. Weber's test will be towards the poorer ear, and airborne and absolute bone conduction will be normal. It is shortened in case of sensorineural hearing loss, but is normal in case of conductive hearing loss. Pure tone audiometry. Pure tone audiometry will reveal conductive hearing loss. This will be seen by the presence of air-bone gap in the pure tone audiometry. And high resolution CT of temporal bone will reveal clouding of air cells. On bacteriological examination, culture and sensitivity is done for appropriate antibiotic usage for treatment. Now we'll look at the treatment of acute suppurative otitis media. So initially antibiotics are given which will be systemic in nature. So ampicillin 50 mg per kg in 4 divided doses or amoxicillin in 40 mg per kg in 3 divided doses may be given. So amoxicillin is more commonly used than ampicillin. If the patient is allergic to penicillins, then erythromycin, cefaclor or cotrimoxazole can be used. So amoxicillin is very important and it is the most commonly used antibiotic, which is systemic antibiotic. If the organism is beta lactamase producing, then amoxiclav or cefuroxime acetyl may also be used. Which is beta lactamase inhibitors. So minimum of 10 days will give these antibiotics. Then we can also use decongestants, relieve the edema and obstruction of the eustachian tube. So we can give either in the form of nasal drops or oral nasal decongestants. So nasal drops will include oxymetazoline, xylometazoline and ephedrine. Oral decongestants would be a pseudoephedrine, which is given 30 milligram twice. Analgesics and antibiotics to reduce the fever and excruciating nature of ear pain. So paracetamol can be given. Then if there is discharge, then ear toileting will be done, which may be with the help of a dry mopping with sterile cotton buds or wick moistened with antibiotic solutions is more useful in this case. Or dry local heat may also be applied, which will relieve pain. Myringotomy can be done. The indications of myringotomy include bulging tympanic membrane, that is bulging drum, which is generally seen in stage 3 of acute suppurative otitis media, or incomplete resolution despite appropriate antibiotic usage, or persistent effusion into the middle ear beyond 12 weeks. So all these are indications of myringotomy. So now we'll see what is myringotomy. So we'll have a basic idea about myringotomy. A J-shaped incision or a curvy linear incision is given in the posterior-inferior quadrant of the tympanic membrane. So as you can see, this is the tympanic membrane of the right ear, and these are the quadrants: the anterior-superior, anterior-inferior, posterior-superior and posterior-inferior quadrant. So a curvy linear incision or a J-shaped incision is given in the posterior-inferior quadrant. So incision should never be given in a posterior-superior quadrant, as all the vital structures are present in the posterior-superior quadrant. Uh, Tympanocentesis. Needle aspiration of fluid from the middle ear is known as tympanocentesis may also be done before myringotomy. Now we'll look at the algorithm of antibiotic usage. So if this acute suppurative otitis media, we'll give antibacterial therapy and then we'll observe the patient after 40 to 22 48 to 72 hours, which is 2 to 3 days. After we observe, if there's good response, we'll continue the same antibiotic for another of 10 days. Or if the earache will persist or increase, then another antibiotic therapy or any antibiotic after culture and sensitivity will be given for 10 days. So we will see if there is resolution or persistence. So if there's complete resolution, then well and good. If there is persistent fluid, but earache and fever resolves, then we will continue the same. Then we'll check the ear after 12 weeks. If there is complete resolution, then nothing needs to be done. But if there is persistent effusion even after 12 weeks, we'll treat it as acute otitis media with effusion. So this was all about acute suppurative otitis media. Thank you.